myaloid muscle, medial pterygoid muscle or the lateral pterygoid muscle, they cannot pull the posterior fragment medially because of the resistance from the anterior fragment, because the fracture line is going or running forwards on the alveolar crest like this. Okay, so if it is like this, it is resisting the movement of the posterior fragment. Exactly opposite if you see here in this particular diagram, if you see here diagram number 2, what is happening is the fracture line is running anteriorly forwards on the alveolar crest, and that's why the anterior fragment here cannot resist the movement of the posterior fragment, and the posterior fragment, because of the attachment of mylohyoid, medial pterygoid and lateral pterygoid, this portion is getting pulled on the medial side, and thus it becomes a vertical unfavorable type of fracture. Now, why the favorable or unfavorable fractures are important? Because whenever you are doing a treatment plan, there are 3 principles of fracture management. First is reduction, second is fixation, and third is immobilization. Now, and there are 2 types of modes of treatment, which is one is called as open reduction and the other is called as the close reduction. In close reduction, actually what we do is we just reduce the fragment, we just manipulate the fragment, we reduce it without opening or without doing the surgery or without seeing the or treating the fracture line by opening it, and you can see or visualize the fracture directly with your naked eye. But in close reduction, what we are exactly doing is just manipulating the fragments, reducing the fragments, and then we are doing some type of immobilization with the help of arch bar and doing IMF or intermaxillary fixation. Now, open reduction is required. In open reduction, we open the whole fracture line, we curate the fracture line. If there is any granulation tissue which is present inside the fracture line, we curate it. Then under direct vision, we reduce the fragments properly, bone to bone contact. Then we do some fixation with the help of some plates or screws, and then you close the wound. So this is called as open reduction. So one is open reduction, the other is close reduction. Now always remember, whenever the fracture is unfavorable, you have to do open reduction. So any unfavorable type of fracture, open reduction. If the fracture is favorable, you can go for a close reduction. So for treatment point of view also, this classification is very, very important. So I think you must have understood this, because this is very, very important. Now, if you want to manage any fracture of the mandible, now there are 2 types of approaches which can be used. One is called as intraoral approach and the other is called as extraoral approach. Now, for extraoral approach, we take a submandibular incision, or it is also called as residence incision, where you make a 1 centimeter incision, 2 finger width or at least 1 finger width below the inferior border of the mandible to save the marginal branch of the mandibular nerve in the crease of the skin. Now once you make the incision on the skin, you open up the cut the subcutaneous tissue, the platysma. Then you can see the 2 groups of submandibular lymph nodes. Between the 2 groups of submandibular lymph nodes, you can see the facial artery and facial vein. You need to ligate the facial artery and facial vein and cut them. Then you can see the pterygomasseteric sling like this, and then you need to cut or make a cut on the pterygomasseteric sling, and then you raise the masseter muscle so that you can see the fracture of the angle of the mandible. So this is the extraoral approach. Even if the fracture is on the ramus of the mandible, then you need to take a Hind's incision, which is also called as a post-ramal approach, from behind, where again you can make an incision in Hind's approach 1 finger width below the posterior border here on this region. 1 finger width behind the posterior border of the ramus of the mandible, and then you can approach the ramus of the mandible or the subcondylar portion with the Hind's incision. So these are the extraoral incisions which can be made to approach the angle fractures or the body fractures or the ramal and subcondylar portion fractures of the mandible. But if you can also treat these fractures by intraoral approach, and nowadays most of the fractures of the mandible can be treated by intraoral approach because of the extraoral scar, which is a problem, aesthetical problem in cases of extraoral approach. So mostly nowadays all the maxillofacial surgeons try to approach or treat the fractures of the mandible by intraoral approach. Now here you can see that this is there is called as a degloving type of incision, also called as a vestibular approach or anterior vestibular approach. Now this type of incision can be used to treat the fractures of the symphysis region or the parasymphysis region, maybe a body of the mandible. And a third molar type of incision can be used like a Ward's incision or modified Ward's incision in cases of fractures of the angle of the mandible. Now I just brief you about the anterior vestibular approach. You have to make an incision. From canine to canine, on in the deepest portion of the vestibule below the attachment of the gingiva, and then you need to raise this mucoperiosteal flap up to the inferior border of the mandible, So you can see any fracture or the fractures in the symphysis or parasymphysis region. Now mind well, here lies the mental nerve which comes out through the mental foramen, so you should not damage the mental nerve. So the proper dissection should be carried out not to damaging the mental nerve. And once you see the fracture, after making the incision, raising the mucoperiosteal flap, before you do the surgery on any fractures, you need to put arch bar. Now there are various types of wirings which can be used, like eyelet wiring, Risdon's wiring, or Gilmer's wiring, or we can put Erich type of arch bar. Commonly we use Erich type of arch bar from 6 to 6, both in maxillary teeth and on the mandibular teeth, because they will help for doing intermaxillary fixation and to restore the occlusion, to see the occlusion during the open surgery. So here, once you make the incision, you see the fracture line, and then you need to do the curettage. You need to do the curettage of the fractured line, because there might be some granulation tissue which is present between the fracture line. So why it is important to remove the granulation tissue? Because if you don't remove the granulation tissue, then there might be non-union, because granulation tissue is a soft tissue, and if it is present between the two fracture segments, and if you don't do the curettage, there will be non-union of the fragments. So doing curettage of the fracture line is very, very important step. Now once you make the incision, as I have told you, you see the fracture, you mobilize the fragment, remove the granulation tissue, and then you do the intermaxillary fixation. Now once you do the intermaxillary fixation, you will understand or know about the occlusion of the patient. If the occlusion is proper, then you can use plates and screws to fix up the fracture, which is called as rigid fixation. Now that will come to know later on. And there are many types of plates and screws which can be used, like we have mini non-compression type of plate, simple non-compression type of plating system, or we have compression type of plating system. Now compression type of plating system basically is not used nowadays, because they were the very thick plates which were used, and it was introduced by Spiegel somewhere in 1937 or something like that. So Spiegel was a person who discovered this compression type of plates. But nowadays we don't use compression type of plates, because these plates are too bulky. The plates are too bulky, and these plates have to put on the inferior border of the mandible. So if you put the plates on the inferior border of the mandible, that means you need to take an extraoral approach. So again, extraoral scar. So bulky plates, extraoral approach, and a lot of force was generated in case of compression plating system. So whenever they were putting plates on the inferior border of the mandible, what was happening was the superior border. So if this is a mandible, this is the superior border of the mandible, and this is the inferior border of the mandible. If you put a plate on the compression type of plate on the inferior border of the mandible, so once you try to tighten the screws on the compression plate, the superior border opens up like this. The superior border opens up like this. So that was a problem with the compression plating system, and it used to generate so much force that to treat your actually you are treating one fracture, but you might create one more fracture. So bulky plates and all these were disadvantages of compression plating system. So nowadays we don't use compression plating system. We use only simple non-compression type of plates, which are called as mini plates, and it is called as chamfer system. I will come to that, what are chamfer osteosynthesis lines. So here I just want to tell you that once you do the fixation, there are various types of plates and screws. We have 2-hole with gap, 4-hole with gap, continuous plate. We have orbita shaped plate. There are Y-shaped plates which can be used for frontonasal suture fracture. We have orbita shaped plate which can be used for fractures of the infraorbital rim. And there are 4-hole with gap plates, and there are condylar neck fracture plates. So there are various types of plates which are available, and the latest plating system which is used is biologically resorbable plates and screws. But the problem with them is they are very what you can say, they are not that cheap. They are and secondly, they take some time to get resolved, but they are good plates. But most commonly these type of plates are used in cranial surgeries by neurosurgeons. In the cranial bone fractures, or if you are taking some cranial bone graft and then you need to put some plate in the cranium, then these biologically resorbable plates are used. So here you can see that once you put the plates, now how do you put a plate? Now most commonly the plate which is used is the chamfer plate, and the thickness of the plate is 2 millimeter, and there are two types of screws which are available, which are called as monocortical screws and bicortical screws. Now what are these monocortical screws? As you all know that there are two cortices. So if the screw only goes into the one of the cortex, if it goes just in one of the cortex, it is called as monocortical. If you pierce both the cortices, then they are called as bicortical screws. So there are various lengths of screws which are available, starting from 6 millimeter, then 8 millimeter, then 10 millimeter length of screws. Now whenever you are putting a plate in the inferior border of the mandible, you can use 10 millimeter or 8 millimeter length screws. But if you are putting the plate just near the root of the tooth, in such cases you need to put 6 millimeter length of screw, because if you use more length of screw, you may damage the root of the teeth. Similarly, if you are using screws in the maxilla, as maxilla is a membranous bone and the cortical bones are thin, you need to use 6 millimeter length screws in cases of maxilla. Okay, so this is the plating system. Then there is one instrument which is called as a drill bit. The instrument is called as drill bit. Now this drill bit, suppose you want to put a screw of say diameter 2 millimeter diameter screw, you want to put it inside the bone, you need to use the drill bit of 1.5 millimeter. Okay, because the rest of, if you want to tighten the screw, then the screw diameter should, your drill bit diameter should be less than that of the screw. So once you drill the hole with the help of drill bit of 1.5 millimeter, then you put the screw with the help of screw holder, and then with the help of screwdriver you tighten the screws. Okay. So once everything is done, then you suture this wound. Now you remove the intermaxillary fixation and you suture the wound in layers. So in the anterior region or the posterior region, we need to do 2-layer suturing. Mostly in the anterior region, we need to do 2-layer suturing, subcutaneous tissue to subcutaneous tissue, and then mucosa to mucosa. And subcutaneous tissue suturing is done by resorbable suture material like Vicryl, and mucosa to mucosa suturing is done with the help of 3-0 black silk. That is a non-resorbable suture material, and you close the wound. Similarly, it can be done in the posterior angle of the mandible, where in the angle of the mandible you put a 4-hole with gap plate on the external oblique ridge. 4-hole with gap plate on the external oblique ridge. Now why 4-hole with gap, why on external oblique ridge, that you come to know here. Now as you see on the mandible, you see this particular diagram. On the mandible there are two types of stresses which actually act. So one is the superior border, the other is the inferior border. So on the superior border there are compressive stresses. On the superior border there are compressive stresses, and on the inferior border there are tensile stresses. Now there was one fellow which he was called as Shamfi. What he did was he did some research on where these both these stresses are equal on the mandible, the compressive stresses and the tensile stresses. Then he found out some points on the mandible like this. Okay, so he found that he drew two lines on the symphysis and the parasymphysis region. So these are the two lines. The first line you can see here is drawn 2 to 3 millimeters below the root apices of the mandibular anterior teeth till the mental foramen. Okay, and one more line he drew just 5 millimeter above the inferior border of the mandible. Okay, now these two lines he drew, and from the mental foramen there was a single line here, and behind that this line was extending and going up on the external oblique ridge like this. Okay, so he suggested that both these forces, compressive as well as the tensile, they are equal, and if you do the plating on these lines which are suggested or which are called as ideal osteosynthesis lines given by Shamfi, then there will be no problem in the treatment of that fracture or healing of that fracture. So that's why whenever there is a fracture of symphysis, we put 4-hole with gap plates. We put 4-hole with gap plates, 2 4-hole with gap plates, one just below the root apices of the mandibular anterior teeth and the other on the 5 millimeters above the inferior border of the mandible. Similarly, in cases of parasymphysis fracture, then if there is any fracture on the body region here, then you need to put 1 4-hole with gap plate here. And if there is fracture of the angle of the mandible, something like this, then you need to put a 4-hole with gap plate here, that is on the external oblique ridge. If you want to approach the external oblique ridge, you need to take a incision, like I have already explained to you last time, Ward's incision, or you can take modified Ward's incision, and you can do the plating on the external oblique ridge here. So this is all about ideal osteosynthesis lines of the mandible. Yeah, I am trying to, somebody is telling me please use the mouse. Yes, I am trying to use the mouse and trying to explain whatever I can on this slide with the help of the mouse. Don't worry. Somebody is asking me about the suturing. Okay. Here you can see that whenever we are making an incision and we raise a mucoperiosteal flap, that is mucosa along with the periosteum, and once we make the incision, we raise the mucoperiosteal flap. What we need to do is, when we close the wound, we need to suture the wound. We suture the wound. Now there are two layers, one is subcutaneous tissue and one is the mucosa. Okay, so we need to suture mucosa to mucosa, subcutaneous tissue to subcutaneous tissue, sometimes muscle to muscle. So the deeper suturing is done with the help of absorbable suture material like Vicryl or say catgut, maybe plain catgut or chromic catgut. But the suturing which is done on top, that is mucosa to mucosa, it is done with the help of 3-0 black silk or 3-0 mer silk. Okay, that is a non-absorbable suture material. Now, if you want to suture on the skin, then the layers below the skin, like subcutaneous tissue to subcutaneous tissue or platysma to platysma or muscle to muscle, they are all sutured with Vicryl, which is again absorbable. But if you want to suture skin to skin, here we don't use mer silk because skin is a delicate structure. So what we do is we use 5-0 or 4-0 ethylone. Again, it is a non-absorbable type of suture material. Now you can see this picture here. This is a typical picture of bucket handle type of fracture. I wanted to show this diagram. You can see here, these are the muscles which are attached to the mandible. This is a severely atrophic ridge, mandibular ridge, and this is the body. Again, you can see very lot of atrophy is being here. Edentulous mandible. This is the hyoid bone here. So you can see there is attachment of mylohyoid muscle. Then there is attachment of geniohyoid muscle. You can see here, this is a geniohyoid. Then you have a genioglossus muscle. Now it is very common that there is a fracture of bilateral parasymphysis or body fracture of the edentulous mandible. So in such cases you can see that because of the attachment of the geniohyoid muscle, genioglossus muscle, you can see this is a geniohyoid, this is a genioglossus and mylohyoid muscle, this particular fragment here is displaced posteriorly and downwards. You can see displaced posteriorly and downwards, and this particular body or rather the bone, you can see it looks like or appear like a handle of the bucket, and that's why it is called as bucket handle type of fracture. So downwards and backwards or posteriorly and backwards, this particular fragment will get displaced. This is how the influence of the muscle on the fracture takes place. Now if there is edentulous fracture, there is something called as gunning type of splint. In edentulous mandibular fracture, I just want to make a note of one point, that if you see the edentulous mandible, now basically the mandible is based on two types of blood supply. One is called as the endosteal blood supply, or rather the central blood supply, and the other is called as the peripheral type of blood supply. The central blood supply is through the inferior alveolar artery, whereas the peripheral blood supply to the mandible is through the periosteum. That is, periosteum is the Haversial canal, and then the periosteum there is a peripheral blood supply. Now as the patient goes elderly, in those such patients, what happens to the inferior alveolar artery is that there is atherosclerosis. How there is atherosclerosis of the coronary artery? There is atherosclerosis of the inferior alveolar artery. So mostly in the edentulous mandible, the blood supply is of peripheral type, or peripheral blood supply, or the periosteal blood supply. So in such cases it is very difficult to do the surgery or raise the mucoperiosteal flap, because once you raise the mucoperiosteal flap, the problem is the healing in edentulous mandible, because the whole the mandible is based on the periosteal blood supply, and if you are making the incision and raising the mucoperiosteal flap, you are cutting down actually the peripheral blood supply. So more chances of osteomyelitis, more chances of non-healing of the edentulous mandibular fractures. So mostly or commonly what we do is we try to do close reduction in cases of edentulous mandibular fractures if at all possible, and this is the gunning type of splint which is used. This is called as a mandibular gunning splint. Now the gunning splint, either it can be used or it can be made on the existing complete denture of the patient, or if the patient doesn't have denture but the mandible is edentulous, in such case you might prepare such a type of splint. This is a mandibular gunning splint. Similarly, you can prepare a maxillary gunning splint. If the patient is a complete denture, where you may remove or extract remove the anterior teeth from canine to canine on the maxillary denture, then similarly on the mandibular denture, and you can place such two hooks. You can see here there are two hooks which are made in the mandibular denture. Mandibular denture, you can put the hooks facing downwards, and in the maxillary denture the hooks can be facing upwards, so that once you place the dentures, then you can do the intermaxillary fixation with the help of these particular hooks. You can place elastics, or you may place wires to do the close reduction of the maxilla and the mandible. So this is called as gunning type of splint. Now once you have to put a gunning type of splint, now how you retain this particular splint on the mandible? So if you want to retain this mandibular the splint, gunning splint, what you do is you reduce the fracture of the mandible, put the gunning splint like this on the mandible, okay, and then there is one instrument which is called as the bone awl. Bone awl is an instrument. If you have sometimes gone to the cobbler, now if you आपका कभी सैंडल या कुछ चप्पल अगर टूट जाता है या फट जाता है, तो आप मूची के पास जाते हैं और वो एक इंस्ट्रूमेंट रहता है उसके पास जिससे वो सिलाई करते हैं. He stitches your chappal or sandal with that instrument. If you remember, there is one this sharp instrument, a sharp point is there, and there is one small hole at the end of that instrument, and with that he passes his what you can say, the thread, and then he starts suturing or stitching. So similar type of bone awl is available, what you do is you pass the bone awl from here, that is from the skin. If you see here, there is an inferior border of the mandible. So you pass it from here and take it out from the lingual sulcus of the mandible. So once you put this from the lingual sulcus, from here your bone awl will come out inside the oral cavity. Then you put one particular wire and inside that bone awl, and then you take out the bone awl, okay, from the skin. So the wire, along with the bone awl, the wire will also come out through the skin, and then you again place the bone awl and take it out from the buccal side, from here, from the buccal side in the canine region, and the other end of the wire you pass it in the hole of the bone awl, and along with the bone awl, once you take the bone awl out here from the buccal side, the wire will also come out, and then both these wires here, which they come out, you just twist them and tuck them inside tightly, and they will go inside the skin. So this is called as circummandibular type of wiring. So your mandibular denture is fixed to the on the mandible with the help of circummandibular type of wiring. Similarly, for the maxillary denture, similar type of maxillary gunning splint can be prepared, and the maxillary denture, they are actually fixed with the help of per-alveolar type of wiring. Again, in per-alveolar type of wiring, you have to make some holes in the maxillary denture. So suppose this is a maxillary denture, so you make 2 holes, because on the there is a alveolar ridge and there is a deep palate here. So you make 2 holes on the buccal side of the denture, which comes out on the palatal aspect. So one hole here, one hole, and both in the canine region, and you need to make 2 holes in the palatal aspect. On the palatal aspect of the denture, you make 2 holes, and like this you pass the wire, then one from the palatal aspect of the denture, and similarly you take it out from the buccal aspect, then you tighten it. So this is called as per-alveolar type of wiring. So the maxillary denture is fixed, maxillary gunning splint is fixed with the help of per-alveolar wiring, and the mandibular one with the circummandibular wiring. And then once it is fixed, you can put elastics or some wires so that you do the intermaxillary fixation. Now if the patient is a child, intermaxillary fixation is only required for 15 days or maybe 2 to 3 weeks. But if the patient is young adult, you can put for 3 to 4 weeks. But if the patient is elderly, it requires more time for bone healing, and then you have to put this intermaxillary fixation for at least 6 weeks or sometimes 6 to 8 weeks. This is all about the mandibular edentulous fracture. Now there is something called as guardsman fracture or parade ground fracture. Now in guardsman fracture, what happens, if you must have seen the soldiers who are doing the parade, so many times they fall only on the chin. So if they fall on the chin, many times either the symphysis fracture will occur only, or there might be symphysis fracture and both the neck of the condyle fracture, or there might be a condylar fracture of both the sides. So either symphysis fracture or symphysis plus both the condyles, or only both the condyles and not the symphysis. Okay, so this is called as guardsman type of fracture or parade ground type of fracture. Now again, in mandibular fracture there is one sign which is called as Coleman sign, C-O-L-E-M-A-N-S or C-O-L-E-M-A-N-S, Coleman sign. Coleman sign is nothing but it's a pathognomic sign which is seen in the fractures of the mandible, and it is nothing but the sublingual hematoma which can be seen, which is pathognomic of fractures of the mandible. Now this is all about the fractures of the mandible. Now next I want to talk about the fractures of the middle 1/3 of the facial skeleton. Now the very important diagram, I want to talk about this before I go for the next thing, the MCQs. If you see that this is the skull, here you can see the skull. Now this is, here you can see is called as the base of the skull. This is the base of the skull. The middle 1/3 area, you can see here, this is typically it is like a matchbox shape of the matchbox. You can see here, this is the middle 1/3 area of the facial skeleton, and then here you can see this is the mandible. Okay. Now, whenever there is trauma to this matchbox, you can see this is a matchbox, this is the base of the skull. So whenever the forces are acting from anterior direction, where this matchbox will go, now this matchbox will go or get displaced posteriorly and downwards. So this will go posteriorly and downwards. So there might be a MCQ on this, and this is very, very important, because if your basic concepts are clear, it becomes very easy to answer any type of questions. So this is a matchbox here, this representing in the middle 1/3 of the facial skeleton. Whenever there is trauma or forces are there from the anterior side, this matchbox will slide or go posteriorly and downwards, posteriorly and downwards. This is one very, very important diagram. The other diagram which is very, very important, if you know this diagram well, then and then only I can explain you about the 3 fracture lines, basically the Lafort 1, Lafort 2 and Lafort 3 fracture line. So I want you all to concentrate on this particular diagram. Now if you see here, this is the frontal bone here. You can see here, this is the frontal bone, this is the nasal bone, then this is your maxilla or maxillary bone or maxillary process or frontal process of the maxilla. Then you can see here, this is called as the lacrimal bone. You can see this is called as a lacrimal bone. Behind the lacrimal bone lies the ethmoidal bone, and behind the ethmoidal bone lies the sphenoidal bone. This is one of my favorite diagrams, very, very important diagram. And one should know about this diagram if you want to talk about the fracture lines of the middle 1/3 of the facial skeleton. And mind well, if you know all these 3 fracture lines well, it becomes very, very easy to talk about the clinical features of these fractures and the treatment of these fractures. Okay, so to understand these 3 fracture lines, you should understand the anatomy first. The anatomy says that this is the which bone? This is the frontal bone, this is the nasal bone. Behind the nasal bone is the frontal process of the maxilla. Behind that, this is called as the medial wall of the orbit. On the medial wall of the orbit, the first bone here lies is called as the lacrimal bone. Behind the lacrimal bone is the ethmoidal bone, and behind the ethmoidal bone you can see this is called as the sphenoidal bone, and just near the sphenoidal bone lies the optic foramen, through which comes out the optic nerve. Okay, so I think you all have understood this. Now this is a nasal aperture. This is also called as the pyriform aperture. This nasal aperture is also called as pyriform aperture. So once this is clear, now there are various lines. We call it as vertical lines, and the other is called as horizontal lines. So this is the horizontal line you can see here, and the others are the vertical lines. Excuse me. Like as I have told you about the ideal osteosynthesis lines on the mandible, similarly there are 3 vertical lines which a surgeon should know, which actually supports the middle 1/3 area, and the 3 horizontal lines which you should know, which supports the middle 1/3 in the horizontal plane. Now why these lines are important? Because the plating system or the rigid fixation is done, and we put the plates on these particular lines. Okay, if you see there are 3 lines or 3 pillars. These are also called as pillars. So if you see, this is called as the anterior pillar. This particular line is called as the anterior pillar. This is called as the middle pillar, and this is called as the 3rd posterior pillar or the pterygoid pillar. So pterygoid pillar, middle pillar, or the zygomatic pillar, or you can canine pillar, or this is the anterior pillar. If you see the anterior pillar, this particular line runs from the canine region up on the lateral wall of the nasal aperture, then it goes up here and it goes up to the frontonasal bone, right, till the glabella. So this is called as the anterior pillar. That's why whenever there is fracture, say Lafort 1 fracture, you put one L-shaped plate, inverted L-shaped plate in this particular area, which is called the pyriform aperture area, to support the anterior pillar. So anterior pillar, also called as the canine pillar, it runs from the canine region, goes up near the canine fossa, then on the lateral wall of the pyriform aperture, then on the frontonasal area, goes to the glabella. So anterior pillar. Second pillar is called as the zygomatic pillar. You can see here the middle pillar or the zygomatic pillar. It runs from the zygomatic buttress. It runs from the zygomatic buttress up to the malar area. This is the malar area, and then it divides into two. You can see here it divides into two. One goes on the frontozygomatic suture above, and the other line you can see here it goes on the zygomatic-temporal suture on the temporal bone. So this is called as a zygomatic pillar or the middle pillar. So when in horizontal fracture, Guerin's fracture or Lafort 1 fracture, you put two plates, one L-shaped plate, reverse L-shaped plate on the pyriform aperture, lateral wall of the pyriform aperture, and the other plate on the zygomatic buttress. So this is how you manage the fractures of middle 1/3 of the facial skeleton. The third pillar is the pterygoid pillar, which runs from the pterygoid humulus region and it runs on the pterygoid plates. This is the third pillar, but this is very difficult to access this area, so we don't put plates here. So mostly the plates are put on the zygomatic pillar and your anterior pillar. So these are the three vertical pillars which support the middle 1/3 of the facial skeleton. Now there are other three pillars which are called as the horizontal pillars. The first pillar, if you see horizontally, if you pass one imaginary line from one FZ suture or frontozygomatic suture to the other frontozygomatic suture like this, connecting the two supraorbital rim, so this becomes the superior pillar. So one is superior pillar, then one more middle pillar. You can see one, if you draw a horizontal line passing from the inferior orbital rim like this, then it is called as middle pillar, middle horizontal pillar. And this is the third pillar which runs on the frontal process of the maxilla, like just behind or just below the root apices of the maxillary teeth. You can see here, this is the third pillar, the third horizontal pillar which is supporting the middle 1/3 of the facial skeleton. So these three pillars, that's why whenever there is a fracture of the infraorbital rim, you put one orbita plate on the infraorbital rim. If there is a fracture here, then you put one plate on the FZ suture, like there was a vertical pillar, the zygomatic pillar which was running on the frontozygomatic suture. So this is the importance of these all these six pillars. Now once you have understood these pillars and once you have understood those two diagrams which I have shown you, one is of that matchbox and the other diagram was of the anatomical diagram of frontal bone, nasal bone, maxillary frontal process of the maxilla, lacrimal bone that was on the medial wall of the orbit, lacrimal bone, ethmoidal bone, and the sphenoidal bone. So now we can talk about the different fractures of the middle 1/3 of the facial skeleton. So we have three types of fractures basically. There was one fellow called as René Lafort in 1901. He was an English anatomist. So what he did was, from certain distance he threw some skulls, maybe 5,000 skulls, and then he found a typical three fracture lines which occur in the middle 1/3 area, and he named them as Lafort 1 fracture, Lafort 2 fracture, and Lafort 3 fracture. Now you can see here in this particular diagram, this is called as Lafort 1 fracture. So this is the Lafort 1 fracture area. This pinkish thing is the Lafort 1 fracture area. Similarly here Lafort 1 fracture line is also, or Lafort 1 fracture is also called as subzygomatic type of fracture, as it is below the zygoma. So subzygomatic type of fracture, or it is also called as horizontal fracture, or it is also called as Guerin's fracture. So these are different names for this particular fracture, Laporte 1 fracture. Then you have this second diagram, you can see here, and this is called as Laporte 2 type of fracture, Laporte 2 fracture. So it is also called as again subzygomatic type of fracture, it is called as suprazygomatic type of fracture because it is above the zygoma, above the level of zygoma. So suprazygomatic type. So there is only one subzygomatic type of fracture, and these two other fractures are suprazygomatic type of fracture. This fracture is also called as pyramidal type of fracture. Okay, it is also called as Laporte 2 type of fracture. If you see this third fracture, this is again called as suprazygomatic type of fracture or Laporte 3 fracture, or it is also called as well known as craniofacial disjunction, because if there is a patient having such type of fracture, the whole middle 1/3 area, it comes out from the base of the skull. That's what is called as craniofacial. So face and cranium is divided, so there is a disjunction between cranium and face, so craniofacial disjunction. Okay, so this is the Laporte 3 type of fracture. So we'll now, as you have understood till here, then we can go ahead with these 3 fracture lines. So one by one I am going to talk about these 3 fracture lines, but before coming to that, please note this. This is a newer classification which was given by Marciani in 1993. It is a modified classification given by Laporte, René Laporte. Now here Laporte 1 fracture is here, Laporte 2 fracture is here, Laporte 3 fracture is here, but one more fracture line is added here, which is called as Laporte 4 fracture. You can just read this from Malik. It is given in Malik. I just want to convey one message from here, that there is one more type of fracture which is added by Marciani in 1993, and he called it as Laporte 4 fracture. Laporte 4 fracture is nothing but Laporte 2 or Laporte 3 plus cranial base fracture. Laporte 2 or Laporte 3 plus cranial base fracture is Laporte 4 fracture. Now it's the time to talk about these 3 fracture lines. Mind well, if you understand these 3 fracture lines, it will become easy for you to answer any question on this all the 3 types of fractures. Because if you know the fracture line, you can talk about the clinical features and treatment of the same. So coming to the Laporte 1 fracture line, these are the diagram showing Laporte 1 fracture line. You can also see when I am pointing out on my face. So the Laporte 1 fracture line, I will repeat these twice or thrice. Okay, so please concentrate on this. Laporte 1 fracture line starts from the lateral wall of the pyriform aperture. You can see here, it starts from the lateral wall of the pyriform aperture just above the nasal floor. Just above the nasal floor, this is the nasal floor. So just above the nasal floor, the Laporte 1 fracture line starts from the lateral wall of the pyriform aperture. It goes behind. You can see here, it goes behind and it fractures the frontal or anterofacial part of the maxillary antrum. You can see this is the anterofacial wall of the maxillary antrum. Then the fracture line runs behind and it fractures the zygomatic buttress. So here the fracture line goes behind and it fractures the zygomatic buttress, and then it goes behind, more behind, till it fractures the lower 1/3 of the pterygoid lamina. Okay, so I'll repeat once more. Laporte 1 fracture line starts from the lateral wall of the pyriform aperture just above the nasal crest or the floor of the nose, goes behind, fractures the anterofacial wall of the maxillary antrum, goes behind it, fractures the zygomatic buttress, and goes behind and fractures the lower 1/3 of the pterygoid lamina. Okay, everybody understood? If there is any problem here in these 3 lines, you can just ask me right now, because this is very important, very important. I will tell you again that the Laporte 1 fracture line, it starts from the lateral wall of the, you can see here, this is the pyriform aperture. So lateral wall of the pyriform aperture just above the nasal crest, goes behind, it fractures, you can see here, it fractures the anterofacial wall of the maxillary antrum, goes behind, fractures the zygomatic buttress, and goes behind and fractures the lower 1/3 of the pterygoid lamina. So this is all about the Lafort-1 fracture. So naturally, if there is a Lafort-1 fracture, the patient will have pain, and you can see here the whole maxilla is in the diagram. You can see the whole maxilla is divided or separated from the middle 1/3 area. So this is can be also called as hanging maxilla. Hanging maxilla or hanging maxilla. You can see here this. Okay, because the maxilla is hanging, what is happening is this is the maxilla, this is the mandible. So the maxilla is separated like this, so that both the posterior teeth of the maxilla, they will fall like this. Okay, so the maxilla will drop like this, and then there will be posterior gagging of the occlusion. Posterior gagging of the occlusion. The patient's face will be swollen in this particular region where there is a fracture. Now there is one sign which is called as Gurin sign. Now there are various, there is a controversy what is a Gurin sign, but actually Gurin sign is nothing but the hematoma or ecchymosis which can be seen near the greater palatine foramen, which is giving indication of having a Lafort-1 fracture. Now in some books it is written that the Gurin sign is nothing but the ecchymosis which is seen near the first molar region in the buccal vestibule. So this is also called as Gurin sign. Also ecchymosis which is seen near the greater palatine foramen, it is also called as Gurin sign. Now sometimes Lafort-1 fractures may be associated with a mid-palatine split. Lafort-1 fractures may be associated with mid-palatine split, and if you want to see the mid-palatine split on the radiograph, you have to take a true occlusal view of the maxilla. You have to take occlusal view of the maxilla. So this is all about the Lafort-1 fracture line. Somebody is asking me to repeat. Okay. I will repeat once more Lafort-1 fracture line. Lafort-1 fracture line, as you can see here, it starts from the lateral wall of the pyriform aperture just above the nasal crest. Then you can see on this diagram that it runs behind and it fractures the anterofacial wall of the maxillary antrum. It goes behind, fractures the zygomatic buttress. You can see this is a first molar area. There is a zygomatic buttress. So it fractures the zygomatic buttress. Then it goes behind and it fractures the lower 1/3 of the pterygoid laminum. Okay. Now coming to the next fracture, it is also called as Lafort-2 fracture. Now Lafort-2 fracture line, as please concentrate on this. Lafort-2 fracture line, it starts from the frontonasal suture. You can see here, it starts from the frontonasal suture. This fracture line, it fractures the frontonasal suture, runs on the medial wall of the orbit. Now remember that particular diagram which I have shown you of lacrimal bone, ethmoidal bone and sphenoidal bone on the medial wall of the orbit. So the Lafort-2 fracture